Hello, I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the high pollen count, forgot my antihistamine, might sneeze into the microphone at any point, sorry, primary care pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice, your trainers, or even your antihistamines. Here's what's bubbling up as we dive in search of our pearls for this month. Here's what's coming up this week. It's recently been Deaf Awareness Week, so we thought we'd look at glue ear. And a question that often arises is, should we refer as soon as we suspect? Glue ear, or otitis media with effusion, is a common cause of hearing difficulty, particularly in children. And whilst it often resolves spontaneously, this can take some time and may impact their progress in education, speech, and language development. Would you be confident in spotting it?
Contraception after a diagnosis of breast cancer. How can we support choice? Breast cancer is the most common cancer in women of reproductive age, and many women will continue to be sexually active during and beyond treatment. They'll usually need to avoid pregnancy during treatment and for at least 2 years after. But how do we help them to find the most suitable method for them and support their choice? We'll look at the 3 key messages from the Faculty of Sexual and Reproductive Health, or FSRH's guidance in 2023.
Physical health and severe mental illness. Can we reduce significant health inequalities? Did you know that people living with severe mental illness face one of the greatest health equality gaps in the UK? Their life expectancy is 15 to 20 years less than that of the general population, largely due to preventable physical illness, particularly cardiovascular disease. So, what can we do in general practice to make a difference? We'll dive into this and think about small changes that we can make to have a big impact. And here's what's coming up next week.
I've brought my gut health profile for you to add to my medical record. Is it worth taking probiotic supplements? The gut health revolution is here. Everyone and anyone is talking about it. Sharing what is known and what just isn't known is an important part of shared decision making with patients. So, what do we need to know? And how can we tell the facts from the noise?
And it's a bumper month this month with 5 pearls. And as it was recently World Multiple Sclerosis Day, we think about how we can suspect it and support patients. Multiple sclerosis often presents in early adulthood, and a diagnosis is life-changing. The challenges in general practice are suspecting it and referring appropriately, and supporting with symptom management. Join us to explore these together. And we start at the top of the list with our first pearl, and glue ear. Should we refer as soon as we suspect? Now, glue ear, or otitis media with effusion, is a common cause of hearing difficulty, particularly in children. Now, whilst it often resolves spontaneously, this can take some time, and associated hearing difficulties may impact educational progress, speech, and language development. Now, this one took me 8 minutes and 32 seconds to read, and exactly 11 minutes and 39 seconds to watch the video bite. Oh, I love a good video bite. So let's take a look. Now, NICE updated its guidance in 2023 and recommended that if we suspect the condition in primary care, then we should refer immediately for audiology assessment. Now, we really want to avoid that hearing impairment and effect on their development in general. Now, they favour this approach because earlier detection and management of the hearing impairment is likely to improve quality of life and reduce the impact of the condition on wider educational and social factors. So let me ask you, would you be confident in spotting it? And if so, do you currently refer when you suspect? So that could be one of our action points already. Ali, what do you think?
Yeah, it's a tough one. I think I'm sure I could be better at this. And if I'm honest, I'm never really that sure what I'm looking for on examination when it comes to otitis media with effusion. And it's also hard because then if we're relying on symptoms and history, we need the parents and the children to come and see us and tell us about those symptoms for us to help. So I suppose it's one as well where we need to keep our antennae up for if a child's actually in about something else, but you notice or the family mention any symptoms that sort of might alert us.
Yeah, absolutely. And one of the good things is that NICE have made our lives easier for us, and we love those kind of moments. And NICE say that we don't have to diagnose glue ear with an otoscope. Instead, we suspect glue ear clinically by the way they present and then examine to rule out any other causes.
Oh, that feels a bit easier, actually, doesn't it?
Yeah.
Okay, so thinking about then when to suspect, that would be if there are any hearing difficulties or if there is delayed speech or language development.
Yeah, exactly. And also if there's any tinnitus or ear discomfort.
Yeah, and NICE lists several conditions and say that if these conditions are present, this raises the index of suspicion of otitis media with effusion. And I have to admit, some of these were new to me. So they include upper respiratory tract infections or otitis media, conjunctivitis, atopy, and snoring.
Yeah, and also craniofacial abnormalities. So if the child's got Down syndrome or a cleft palate, if there is dyspnea, or if there is mouth breathing or sucking habits such as using a dummy, bottle feeding, thumb sucking, all those kind of things. Now, NICE also lists 3 things, the absence of which reduces the index of suspicion of otitis media with effusion. And they are nasal obstruction, rhinorrhea, and adenoid hypertrophy.
Okay, and then thinking about the wider reaching implications, so we need to be alert to this diagnosis if a child is presenting with behavioural problems, poor educational progress, or balance problems or clumsiness.
So the bottom line is that if we have that clinical presentation of glue ear, then we should treat it as suspected glue ear, and it's really that simple.
That's great, actually, isn't it?
Yeah, and...
Oh, there's always an and, isn't there?
Yeah, you're not wrong. And NICE say that if otitis media with effusion is clinically suspected, we refer for formal assessment, which should include otoscopy, audiology and tympanometry, because glue ear is all about hearing and the impact. And the rationale is that the earlier that we can do this, the better the outcomes are. Now, Ali, I'm never sure what happens, though, sort of once I do that referral. So can you talk us through that?
Yes. So where hearing loss is present, then children will be offered advice and reassessment after 3 months or sooner if the hearing loss is significantly affecting day-to-day living. And we're going to tell you in a minute more about what that advice involves. Then at 3 months, if there's no hearing loss, they're discharged, again with advice. If there's unilateral hearing loss, they'll reiterate the advice and consider a further 3-month review unless hearing loss is impacting daily living or communication, in which case they'll then move to the management strategies that we're also going to tell you about in a minute. And then if there's bilateral hearing loss, they will follow those management strategies straight away. So I've mentioned the advice that secondary care give a few times now. So Nick, can you tell us about that advice that we're obviously going to be backing up in primary care?
Yeah, so NICE suggests that for all children with glue ear and hearing loss, then we offer the following advice. So firstly, avoid exposure to tobacco smoke, which in most cases will be avoiding parental tobacco smoke. So I was kind of thinking about that. What's the link there? So we dug into the evidence for NICE's guidance, and unfortunately, there isn't much there. And what evidence there was is low quality. So this comes down to consensus, thinking about the harms of passive smoking for children and how it might affect developing respiratory infections. And of course, it's something that we should be recommending anyway. We digress. So back to the NICE advice. And remember, I was saying that NICE suggests that this advice is for all children with glue ear and hearing loss. And I've just mentioned avoiding tobacco smoke. Next, we have general measures around the hearing side of things and communication. So we should set expectations that hearing may fluctuate and resolution takes weeks to months. Parents should inform teachers and other caregivers so that adjustments can be made. And when communicating with the child, we should face them, be close when speaking, and minimise the background noise.
Okay, so that all sounds pretty doable. So that's another nice little nugget for the action plan.
Absolutely. And so what have you got for us on management strategies, Ali?
Okay, so these are obviously all done in secondary care, but it's worth knowing about them because parents might well ask about them. So they include hearing aids, which weren't at the top of my list before I read the Pearl. And these hearing aids might be either air conduction or bone conduction devices. So air conduction devices are considered when the hearing loss is not fluctuating and when it's felt that those would be better tolerated or preferred to a bone conduction device. And then Conversely, the bone conduction devices are used when hearing loss does fluctuate or if there's contraindications to air conducting devices such as otorrhea, or again, just if that's the preference or it's better tolerated.
Another non-surgical option would be to consider an auto-inflation device if the patient is able to engage with the treatment. So more on that in a moment. Surgical options are to consider grommets and to consider adjuvant adenoidectomy, and more on that in a moment as well. Now, you've got some things that NICE don't recommend there too, haven't you, Ali?
Yes, and some of these might be a change in practice for us too. So firstly, NICE does not recommend antibiotics, and it also doesn't recommend other pharmacological interventions, including oral or nasal steroids, antihistamines, PPI, anti-reflux meds, leukotriene receptor antagonists, mucolytics, or decongestants. NICE don't want us to use any of those. And then there's some other non-surgical treatments that NICE don't recommend as well, including homeopathy, cranial osteopathy, acupuncture, dietary modifications, probiotics, and massage. To be fair, I don't think I was using any of those for
me neither.
for otitis media with effusion before. But just going back then to what might be a big change in practice for most of us, do we really refer as soon as we suspect glue ear, Nick?
Well, yes. NICE suggests referring all children with suspected glue ear for formal audiological assessment rather than adopting a period of watchful waiting. The rationale is that better and earlier recognition and management of hearing impairment is likely to improve educational outcomes, child development and quality of life, which may offset the increased costs of early referral. Now, I mentioned in the surgical management options about adenoidectomy, so that's new. What can you tell us about that, Ali?
Yes, so as you say, there's this new recommendation from NICE for adenoidectomy to be considered in addition to grommet insertion for children being referred for surgical intervention for glue ear. So what NICE say is that adenoidectomy would present a minimal amount of additional risk in a child already having a general anaesthetic, and that it may actually improve hearing over and above grommet insertion alone. And that the benefits in terms of hearing improvement from adding in that adenoidectomy are likely to outweigh the risks. So Nick, wrapping up on management, what does NICE say about these autoinflation devices?
So NICE suggests that we consider autoinflation devices for children with glue ear if they're able to use them. And it identified low quality evidence that autoinflation improves hearing in the short term under 6 weeks compared with no intervention. Now, if you've not come across these before, then they are special balloon devices, not party balloons. You mustn't use those. And basically, you blow them up through the nostril, and this results in the pressure in the middle ear being equalised. So a click or a pop will be heard, and these should be used 2 to 3 times a day for 2 to 4 weeks. And we'll put a link in the show notes to an instruction video about this. And Kate also demonstrates it beautifully in the video Byte with Susan. And so watch really carefully, because there's a lovely moment where Kate starts to laugh while she's waiting for Susan's instructions. And so there's a link to that in the show notes as well. Now, Ali, you mentioned earlier that steroids were a no-no in glue ear, so I suspect that this warrants a dramatic sound effect, especially concerning nasal steroids. So what's this all about?
Oh, the drama, Nick. That's right. NICE does not recommend oral or nasal steroids for otitis media with effusion or effusion-related hearing loss. And its decision is based on a Cochrane review. So that's Cochrane 2023 CD 015255, if you want to go look it up, which included 27 studies involving almost 3,000 children. And NICE's conclusion, having looked at that, was that oral or nasal steroids may reduce otitis media with effusion in the short and very short term only, and that steroids are known to have potential long-term side effects. Nasal steroids can be tricky for children to use, and all of the evidence that they looked at was of very low quality, and the benefits were not felt to outweigh the potential harms. So that's a what not to do learning point for us.
Yes, so that I haven't got a sound effect for that, but here are your learning points for otitis media with effusion. Suspected on the basis of the clinical presentation.
Refer for formal audiological assessment if suspected.
And offer advice and consider autoinflation. So there we go, a nice quick one to start off the month. Ali, how are you doing?
Yes, I'm good, thank you. I've just been on a little holiday actually to Spain with the kids, and during that holiday, one of their favourite games to play in the swimming pool was put your goggles on, swim underwater, and poke mummy in the jiggly bits and look at how long they jiggle for underwater.
Oh my goodness.
So inspired by that, I decided to take up Pilates when I got back. So I've been going to, I don't know, have you heard of reformer Pilates, where you there's these special beds that you lie on?
No, I haven't.
Oh, they look a bit like sort of medieval torture devices. They've got all these loops and pulls and things. So the reason it appealed to me is because most of the class is lying down on these beds. But it actually, so I've got really into it. I've been to the last 3 days. I've been to daily classes, and I might have overdone it a bit because today I couldn't really get out of bed. My abs hurt so much that I had to push myself up out of bed.
Good sign. That's a good sign when that happens.
Yeah, exactly. Yeah. So I'm doing a bit of self-care.
Oh, well, I'm going off to Dorset for a couple of weeks holiday imminently.
That's nice.
This is very exciting. And so I was thinking about what I can take with me fitness-wise, as in what equipment I can have. And obviously, you can't pack a load of weights to take into the car, because we all need to be making sure that we've got enough muscle mass to make sure that in the future we will not fall over, hopefully.
Yeah.
So that I have now ordered some of those resistance bands, which are obviously very light, but they're also meant to be really good for building muscle and stuff, or maintaining muscle. So I'm taking those with me so that I don't decline in the 2 weeks that I'm away.
Nice.
Not that I'm panicking. So it's all good.
Next time we record, we can compare muscles, can't we?
Exactly. So shall we move on to our second pearl?
Let's do it.
Okay, excellent. So now this one is contraception after a diagnosis of breast cancer, supporting choice. Now, breast cancer is the commonest cancer in women of reproductive age, accounting for around 43% of all cancers in women aged 25 to 49 years. Now, around 18% of breast cancers occur in premenopausal women. Pregnancy should generally be avoided during breast cancer treatment. This is because the hormonal state of pregnancy may affect disease progression in the short term. Surgery requires anaesthesia, which should be minimised during pregnancy. And treatments are teratogenic, or they may have unknown effects on a developing fetus. Now, this one took me 11 minutes and 2 seconds to read, so a nice cup of green tea with pear, perhaps.
Oh, are you talking about sort of drinking a green tea and having some pear on the side, or is this a special type of flavour?
Special brew that you can buy from any good supermarket. But the reason is that I'm not advertising it, but if anybody that has drunk green tea, it can be really bitter, particularly if you let it brew for longer than, say, 3 minutes or so. Never squeeze the bag either. But you can get versions with kind of mint, and this one's got pear in it. And actually it makes it a little bit more palatable. And so there we are. Anyway, enough about tea. What did this pearl mean for you, Ali?
Tea is very important, Nick. But yes. So thinking of this idea of contraception and pregnancy post breast cancer actually makes me think of something a bit personal, actually, which is a very dear friend of mine who had her beautiful little girl following treatment for her breast cancer. And in this pearl, we're going to think about the very practical side of choosing contraception, but I suppose it just made me reflect about that for the patients who we see in this scenario. These decisions sit in a world of very deep emotional complexity. And I suppose, as we've said before around topics like this, if we know what we're doing on the practical side, it then makes focusing on the emotional support side a lot easier, doesn't it? So it's really worthwhile. Yeah,
and in this kind of situation, often it means so much to the patients when they feel understood. And it's coming to it from that angle as well, isn't it? So So by looking at this now, then we can be prepared if we have a consultation that takes us by surprise, perhaps if we're not expecting it.
Yeah.
So how long after breast cancer should pregnancy be delayed?
Well, to answer that, we need to turn to the Royal College of Obstetrics and Gynecology's Pregnancy and Breast Cancer Green Top Guideline, which was published back in March 2011. And what they say is that the consensus is, in general, women should wait to conceive for at least 2 years after treatment is complete, because the risk of recurrence is highest during that time. And hormonal treatment with tamoxifen usually continues for 5 years and is contraindicated in pregnancy due to risk of harm to the fetus. So for patients on tamoxifen, conception within that period would mean a disruption of a treatment that's proven to reduce recurrence. So discussions with specialists in oncology and fertility and obstetrics on an individual basis are a very good idea to enable a patient and her partner to make an informed shared decision.
Now, if we look at contraception needs after a diagnosis of breast cancer, this brings us to our first key message, and that is that medical treatments for breast cancer may cause amenorrhea, but they do not provide contraception. The FSRH doesn't consider tamoxifen, aromatase inhibitors, or GnRH analogues as reliable contraception, and it advises that women under 50 years old who've been amenorrheic during or following medical treatment for breast cancer, including chemotherapy, which may cause ovarian insufficiency during treatment, may regain some ovarian activity and ovulate, irrespective of FSH levels. The FSRH guidance states that a sexually active woman should use effective contraception following a diagnosis of breast cancer unless she is 55 years or more, is 50 years or more and has been naturally amenorrheic for more than 1 year, i.e. is not on any hormonal drug or radiation treatment, has had an FSH level more than 30 taken more than 1 year ago and when she was 50 years or more, and before starting chemotherapy or hormone breast cancer therapy. Also, is aged 40 to 50 years, has not taken any medical treatment for breast cancer, and has been naturally amenorrheic for more than 2 years, or has had surgical treatment which would prevent pregnancy, for example, sterilisation, or the partner has been sterilised, or bilateral oophorectomy or hysterectomy. So what about the contraceptive options following a diagnosis of breast cancer, Ali?
So there's limited evidence looking at the risks associated with hormonal contraception use in women with a history of breast cancer, but because breast cancer can be a hormone-sensitive disease, the FSRH takes a precautionary approach in its recommendations. So if you want to go into the finer details of this, then there's a table in the written Pearl which has the current UK medical eligibility criteria, or UK MEC categories, for the different contraceptive methods. But actually the summary of all this brings us to our second key message, which is if we're looking at first-line options in this scenario, the FSRH recommends highly effective non-hormonal contraception first line, and they especially recommend that for women taking teratogenic medication. And by highly effective non-hormonal contraception, they mean either the copper IUD or female or male sterilisation being vasectomy. And those are around 99% effective, those options. And then thinking about the other methods out there, hormonal methods, they say, should generally be avoided. Barrier methods, so either condoms or diaphragms and caps with spermicide, or fertility awareness methods such as the cycle tracking apps, they say are medically safe, but they're less effective than either the copper IUD or sterilisation. And those fertility awareness methods that rely on menstrual cycles, they might be impacted by breast cancer treatments that can cause menstrual irregularities. So that's worth thinking about as well. So Nick, what about women who develop breast cancer while taking hormonal contraception?
Well, women who are on hormonal contraception at the time of breast cancer diagnosis should stop their method as soon as possible and switch to a non-hormonal alternative. If stopping contraception puts a woman at risk of unintended pregnancy, discontinuation may be delayed until the risk has passed or until specialist advice has been sought. However, combined pill users should switch to an interim progestogen-only method. Combined hormonal contraception should be avoided after any breast cancer due to the potential increased risk of thrombosis as well as breast cancer recurrence. What about emergency contraception after breast cancer, Ali? I can feel our third key message coming on.
Yes, here it is. So the FSRH states that the copper IUD should be first-line emergency contraception due to its efficacy and because it's non-hormonal. If, though, an IUD isn't appropriate, either ulipristal acetate or levonorgestrel oral emergency contraception can be given. And there's an article on Red Whale Knowledge on emergency contraception if you want more information on using that. There's no evidence looking at the safety of emergency contraception in women with a history of breast cancer, but the FSRH regards a one-off dose of an oral hormonal emergency contraception as unlikely to be harmful, and any potential risks likely to be outweighed by the benefit of preventing an unplanned pregnancy.
Now, I know that we've been focusing on contraception after a diagnosis of breast cancer, but if you want some further information on contraception after treatment of other cancers and pre-malignant conditions, then there is a useful table to look at in the written Pearl and in the associated article on Red Whale Knowledge. So here are your learning points for contraception after a diagnosis of breast cancer, supporting choice. Medical treatments for breast cancer may cause amenorrhea, but they do not provide contraception.
The FSRH recommends copper IUD or sterilisation as first-line options for contraception. Hormonal contraception is usually avoided.
Emergency contraception, the copper IUD is the first choice, but erythritol acetate or levonorgestrel can be used. Ali, you've got the calendar there, haven't you?
I certainly have, Nick. So we have just wrapped up filming on our obesity course, so very excited for that to launch. We've got GP update courses running, so the next one is on the 20th of June, so you can join us live online for that if you want to. We've also got a live men's health course running on the 4th of July. And then in mid-July, all of us presenters are getting together in London to plan the next season of courses, aren't we?
Yes, we are. This is all very exciting, so it'll be nice to see people face to face. So, very exciting.
And Nick, our new trainee package has been really popular, hasn't it?
Yes, so the GP Trainee Essential Support Package is exclusively available to GPST MDU members and affiliates. So if you're one of those, then it's free and it's worth £165 and it's designed to build your knowledge and confidence and help you pass your exams. And so what's included, I hear you ask? Well, it's really helpful because it's got Red Whale Knowledge Access, which is over 900 written resources to support you during consultations and also with your CPD. And also the Top AKT Topics Digital Handbook, which covers areas that trainees struggle with most, and webinars throughout the training year to support you with your exam preparation. So if you click on the link, then you can sign up for that. So have you got some T's and C's there, Ali?
I've got the T's and C's. So the package is completely free for MDU affiliate and GPST members, but MDU GPST membership itself does carry a charge to sign up. Our GP Trainee Essentials package is a free benefit of affiliate and GPST MDU membership. And just to define affiliate membership a bit more, if you're a GP trainee in England, you can sign up for free MDU affiliate membership anytime during your training. And then thinking about GPST membership, if you're a GP trainee in Scotland, Northern Ireland or Wales, you can sign up for GP Trainee Essentials free when you become an MDU GPST member. Once you're signed up, you'll receive a code from the MDU so you can get GP Trainee Essentials as a free member benefit.
Okay, so let's move on now to the third part of the month, and we're going to be talking about physical health in severe mental illness. And let's first think about a patient. So Billy is 39 and has a long-standing diagnosis of schizophrenia. He recently came for his annual review with the practice nurse for the first time in years. His mental health was the best it's been in ages, which is probably why she's been able to persuade him to attend. But his blood results were not so good, and they're in your inbox to deal with. The HbA1c is in the 90s, total cholesterol 8.4, Q risk through the roof. Over the next few days, you ring him, you send texts, you ask your receptionist to do the same, but you can't get hold of him. What do you do? And before we delve into how we care for somebody like Billy, let me remind you of that statistic from my introduction, which is really quite shocking. And this is from NHS England in 2024. People with a severe mental illness have a life expectancy which is 15 to 20 years less than the rest of the population. And this is mostly due to preventable physical illness, particularly CVD. Now, this is an area where we can make a huge difference in general practice. And in this Pearl, we think about how best to achieve that. So what does this all mean for you, Ali?
Well, there is a take-home message from this Pearl, which is actually quite meaningful for a lot of reasons. So it's a really useful, simple take-home message. It rhymes, which we love, and that is don't just screen, intervene. And what it's talking about here is that actually we fairly often manage to do the screening in this population, but for various reasons, including unconscious prejudice and bias and other kind of social and health barriers, we don't actually manage to intervene in cardiovascular risk in this group very well. And we've borrowed that rhyming slogan from an academic GP called Helen Lester, who worked at the University of Birmingham when I was there doing my intercalated degree. And she was hugely passionate about this area. And actually, if you want to do a real deep dive, there is a link to a talk on YouTube that she gave to the RCGP on this topic at the end of the written Pearl, if you want to go and have a look at it. But yeah, so it's really, really meaningful, important stuff. And we have to credit Helen Lester, the late Helen Lester, for it. And it's more relevant than ever now because in 2025, the QOF incentive for SMI reviews has just been removed. So there's a risk that the health inequalities for this group of people is going to get even worse. And we mustn't let that happen.
Exactly. And it's about doing the right thing in medicine sometimes, isn't it? Not about just box ticking. And so this is really important. And also, as hopefully will come through as we talk about this further, those interventions that we make when we do make them do make a huge difference.
A massive difference. Yeah, they're really, really valuable.
Okay. So Ali, how do we define severe mental illness in this context?
So according to a public health definition from 2018, severe mental illness, or SMI, refers to any mental illness that's debilitating enough to have a significant long-term impact on the person's ability to engage in functional or occupational activities. So that's a broad definition, and it includes conditions such as schizophrenia and other psychotic disorders, bipolar disorder, and other significant mental health conditions too, such as recurrent major depression. And according to the BJGP in 2023, SMI affects about 3% of the population. So Nick, can you tell us more about the increased risk of morbidity and mortality in severe mental illness, please?
Yes, I can. And these figures are pretty bleak. So adults living with SMI have an almost 5 times increased risk of dying prematurely compared with those living without SMI. And premature deaths of people living with SMI are increasing. And that's from NHS England's Improving the Physical Health of People Living with Severe Mental Illness from 2024. So people living with SMI also have a 6.6 times increased risk of respiratory disease, a 6.5 times increased risk of liver disease, a 4.1 times increased risk of cardiovascular disease, a 2.3 times increased risk of cancer, and are 3 times more likely to lose their natural teeth. So Ali, what's the mechanism behind this? Why is SMI associated with such poor physical outcomes?
So it's complex, and there are lots of factors that contribute to the increased mortality rate. We've gathered them together. They're taken from a couple of sources, the BJGP in 2021, the European Heart Journal in 2024, and that NHS England 2024 document. So one of the causes is higher rates of chronic disease, such as diabetes, hypertension, dyslipidemia, and metabolic syndrome. And then there's also lifestyle factors. So actually around 50% of deaths in people living with SMI are attributable to one thing, and that is smoking. And when we look at smoking rates in the general population, they've significantly decreased from a rate of about 40 to 50% of the general population back in the 70s to, in 2017, just 15%. But when you look at people with SMI, they've remained stable. So smoking rates are still up at around 40 to 50%. And many of those people are heavy smokers. And then there are other unhealthy lifestyle behaviours as well, diet, inactivity, drug and alcohol misuse, and they all contribute to this increased risk of physical illness. There's also medication. So antipsychotics and mood stabilisers do increase life expectancy for people with SMI, probably because of the combination of better mental health and the better engagement with health services that better mental health brings. But medication for SMI can also have side effects that have a negative impact on physical health. So we're talking about things like increased risk of weight gain, diabetes, and altered lipid profiles. And actually, the average weight gain in the first 2 years after initiation of antipsychotics is 12 kilos. So it's a lot. And we may also be less likely to prescribe the correct cardiovascular drugs in patients with SMI. So following myocardial infarction, for example, there was a study that showed that patients with SMI are less likely to receive treatments such as aspirin, beta blockers, statins, or ACE inhibitors. So they're just not being managed as well. And then there's also difficulties with attending screening and follow-up. There's the effects of social disadvantage. And interestingly, genetic factors might have a role as well. So people with schizophrenia appear to be genetically predisposed to cardiovascular disease, even when you adjust for all the other factors that we've just mentioned. And then there is an increased risk of death by suicide in this group, particularly during acute psychotic episodes and around the time of admissions. But it's worth, being really clear that suicide is a much smaller cause of death in severe mental illness than cardiovascular disease. And Nick, you've got a bit more on health inequalities, haven't you?
Yes. So despite the known preventable risk factors, people living with SMI actually often receive poorer physical health care compared with the general population. And this can occur because there may be stigma and discrimination around mental illness, even from health professionals. There may be diagnostic overshadowing where mental health symptoms are more prominent than the co-occurring physical disease. And as a result, clinicians may overlook or downplay physical symptoms in patients with SMI. And also, lack of communication and coordinated working practices can lead to fragmentation of care across different specialities, creating gaps between mental health, primary care and secondary care physicians.
And that brings us to the question of what we can actually do in primary care. And it's all about screening, prevention and early intervention. So remembering that mantra, don't just screen, intervene. So thinking about the screening side first, there is the annual SMI check that we offer in primary care, which should include the core elements of weight or BMI, waist circumference, pulse and blood pressure, fasting glucose or HbA1c. I think most of us will be doing HbA1c for most patients, lipid profile. And then in bipolar disorder, specifically, we're advised to check liver function tests and UNE, thyroid function test, and calcium for those on long-term lithium. We should record alcohol and other drug use status and smoking status. That's the bare minimum, but we should also definitely be thinking about calculating Q risk. And in this group, it's worth saying we need to use Q risk 3, not Q risk 2, because of their specific increased risk. So you might need to go outside the Q risk calculator in your working system and might need to calculate it separately. And we also need to think about family history, might need to do a medication review. We're going to want to talk to our patients about lifestyle and think about wider things as well, like are their immunisations up to date? Do they need counselling around sexual health? Do they need signposted to a dentist because of this increased risk around oral health? And also we should be thinking and asking about the person's social circumstances, so things like housing and employment. And this is something that in most practices is likely to be done not just by GPs, but by the wider clinical team. Maybe there's systems in place where you work for making these reviews happen and following up people who don't attend for screening. And actually a good action point, if you're not sure about that, might be looking into what those systems are where you work. Are they working? And also, what adjustments could you make for patients to make attending screening easier for them? So thinking about those adjustments, Nick, can you tell us about the types of adjustments that people with SMI might benefit from in a practice?
Yes, so reasonable adjustments to support people with SMI to access healthcare might include acknowledging that some people with SMI may avoid health services because of a lack of trust, and it may take time and require many attempts to make contact through multiple channels of communication. So obviously, if, say, a phone call isn't being answered, then you could try a text contact or even a letter in some cases. Also, it's about providing clear information on why somebody's been invited for an annual SMI physical health check, and also what will happen at the appointment and afterwards. Explaining that reasonable adjustments can be made, agreeing with the individual what might be helpful, and documenting that on their medical record. Also things like offering a longer appointment or one at the start or end of the day to avoid needing to sit in a busy waiting room, or offering quieter places to sit if the waiting room is busy, so a side room or something like that if you have one. Encouraging the patient to bring somebody that they trust to appointments is also beneficial, and also supporting the person to see the same clinician where that's possible.
Thank you, Nick. So yes, that's the thinking about the accessing and carrying out screening bit of our don't just screen, intervene mantra. And now for the intervening bit. And just to say, we know this stuff is really difficult. We know it from our own experience. And there was also a qualitative study in the BJGP in 2024 that found that GPs often see this complex primary prevention work in this group as almost unachievable in the current workforce crisis. But as we've said, where we can do it, it's extremely valuable. So with these interventions, thinking first about smoking. So we've already said smoking cessation is the single most effective intervention for improving health outcomes in people with SMI. And Nick, you've got more on that, haven't you?
Yes, Elliot, it doesn't just improve physical health, because stopping smoking is as effective as antidepressants for treating mild to moderate depression. And I didn't know that.
That's amazing, isn't it?
I know. And many people with SMI want to quit smoking. And data demonstrates that they can. And they have a quit rate at 12 months similar to the general population when supported with usual methods. And that's from a paper in Lancet Psychiatry in 2019. And in terms of medication to support quitting, efficacy and safety data for nicotine replacement therapy, varenicline, bupropion, and e-cigarettes suggest that all of those options are effective and safe when used in SMI. Now, we have to be a bit careful about drug levels in people with SMI who quit smoking, don't we, Ali?
Yeah, this is interesting stuff, actually. Stopping smoking can affect how the body metabolizes many psychotropic drugs, including most antipsychotics and some antidepressants. So we've got info on that from the BJGP in 2023, and there's more detail on it in the written Pearl. But basically, this means that prescribing during smoking cessation needs to be carefully coordinated, and we need to be wary that drug levels can fall if smoking's resumed again. But also it actually represents a potential double win for patients, because they might need lower drug doses once they quit smoking. So in the written article, there's a full list of drugs to watch out for in terms of this scenario, but a key message is, if you're in doubt, speak to psychiatry. And then what about intervening when it comes to lifestyle, Nick?
Well, perhaps even more important than educating people with SMI about lifestyle, although we should definitely do this, is helping them to address key social determinants. Now, these might include lack of access to recreation and physical activity, a lack of cooking skills perhaps, a limited budget for food, and also increased alcohol intake. Social prescribers may be able to support us in this. And then thinking about managing abnormal results, then we should help people with SMI and their carers to understand their physical health risks, the benefits of screening, and the plan for feeding back results. And remember that people with SMI will probably derive more benefit from modifying these risk factors than others. For example, hypertensive people with SMI have triple the risk of dying from hypertension-related disease if left untreated compared with hypertensive people without SMI. Where appropriate, we should refer patients with SMI and difficult to manage cardiometabolic risk to places like the lipid clinic or cardiology or endocrine clinics. Data shows that this happens less often than it should. And Ali, what about safe prescribing of antipsychotics?
Well, as we know, long-term antipsychotic use is associated with an increased risk of obesity, diabetes, and cardiovascular disease. And because of that, regular meds reviews for this group are really important in terms of safety and to support deprescribing when we can, when it's clinically appropriate. However, a bit worryingly, a BJGP study found that long-term antipsychotic use in primary care is rising, even though fewer than half of the prescriptions issued are to patients who are on the SMI register. So that suggests a growing use of antipsychotics for non-psychotic or maybe unlicensed conditions. And increasingly, we know that patients are managed in primary care without psychiatrist review, sometimes due to kind of workload pressures. But many GPs, lack the confidence to adjust or stop these drugs without specialist input. And because of that, opportunities for cardiometabolic monitoring and deprescribing might be missed, and that really poses significant risks to patients. So I think there's another possible take action point there, and possibly one that the pharmacy team in your practice might be able to support you with around looking at your antipsychotic prescribing. So we're at our take-home messages for physical health in severe mental illness. People with severe mental illness have significantly higher rates of mortality associated with preventable physical health conditions, particularly cardiovascular disease.
In primary care, we should screen for risk factors and intervene to modify them.
Many patients with severe mental illness want to stop smoking, and they can often successfully quit with support.
Psychotropic drug doses often need downward dose adjustment after smoking cessation due to altered metabolism.
We can improve engagement by making practical adjustments, helping patients and their carers to understand health screening, and working with the wider practice team.
We've just got time for some primary care superheroes.
So our first superhero was nominated anonymously at one of our recent face-to-face courses, and they are Dr. Theo Eze. I think I've got that pronunciation right. It's spelled E-Z-E, and I'm basing that on the Crystal Palace footballer who is Eze. So Dr. Theo Eze, I think, at Evergreen GP Surgery. This person has said they come in every morning with a smile and talk to everyone in the back office to check how they're doing. Oh, that sounds like a fab person to work with.
Absolutely. And the next one we've got here is Dr. Ranjit Jones, who's a GP at Thomas Walker Surgery. She is brilliant and very supportive. Again, it's anonymous, but it says thank you so much. So thank you for that one.
And then a final one, again, came from one of our face-to-face courses, nominated by a GP. She's just given her name as Anita. And the nominee is Maria Tibado Perez, a practice nurse at Hammersmith Surgery.
Excellent. So thank you for all of those. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. So how do you become a member, I hear you ask? Well, if you're listening to us, then you're part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher is all one word and it's all lowercase, RedWhalePod.
So if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. And if you can spare a little more time, then please leave us a nice review. Because of the way algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use the hashtag RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You're also very welcome to email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.